All right, today we are diving deep into the complete diagnostic journey for prostate cancer. We're going to cover everything, from the very first subtle signs all the way to understanding that final pathology report. So, let's get right into it.
So let's kick things off with probably the most important number you're going to hear today, over 98%. What is that? That's the 5-year survival rate for prostate cancer. Now, this statistic tells us one thing loud and clear. Getting an early and accurate diagnosis is, well, it's everything. And that's exactly what we're going to unpack.
So here's our roadmap for today. First, we'll talk about why this cancer so often starts off completely silent. Then, we'll cover the symptoms that can pop up. After that, we'll look at the key diagnostic tools we use, DRE and PSA. Then, we'll walk the path to getting a definitive biopsy. And finally, we will crack the code of the Gleason Score.
Okay, Section 1. Let's start with the really basic but super important question. Just how common is this cancer, and how does it usually even show up on a doctor's radar in the first place?
Well, to put it in perspective, if you take skin cancers out of the equation, prostate cancer is the most common cancer that affects men. We're talking about 1 in 9 men in the United States being diagnosed in their lifetime. So yeah, understanding this is incredibly important for all of us.
And this right here is the central challenge in diagnosing prostate cancer. In its earliest stages, the most treatable stages, it is almost always completely silent. There are no symptoms at all. The vast majority of cases are actually found through routine screening, not because a patient felt like something was wrong.
So what happens when the cancer isn't silent anymore? When symptoms finally do start to show up, they usually fall into one of 2 camps. And these camps can tell us a lot about whether the disease is just localized or if it's unfortunately started to spread.
So on one side, you've got these local symptoms, things like urinary frequency or maybe a weak stream. But here's the clinical pearl. These are much, much more commonly caused by a non-cancerous enlarged prostate, what we call BPH. The symptoms overlap almost perfectly, which can be tricky. But the red flags on the other side, those are way more concerning. Blood in the urine or semen, that always needs a workup. And bone pain, that's a really serious sign that could point toward advanced disease.
And let's just zero in on that bone pain for a second. When prostate cancer does metastasize or spread, its #1 target is the axial skeleton. We're talking the spine, the pelvis, and the ribs. This is exactly why a new, persistent back pain in an older man should immediately raise a red flag for potential prostate cancer. Okay, so if the early disease is silent, how in the world do we find it? This brings us to the 2 foundational tools in our initial workup, the digital rectal exam, or DRE, and the prostate-specific antigen blood test, the PSA.
Let's start with the DRE. A normal prostate should feel smooth and firm, kind of like the fleshy part at the base of your thumb. What you're really feeling for is anything that's out of the ordinary. The key things that make you suspicious are induration, which is basically a hardening of the tissue, a distinct nodule or lump, or any significant asymmetry between the 2 sides of the gland. And next up, we have the PSA test. So PSA is a protein that's made by all prostate cells. And notice I said all prostate cells, not just the cancer cells. That one single fact is really the key to understanding both the power and the limitations of this test.
And this leads us to the single most important high-yield takeaway about the PSA test. It is organ-specific, but it is absolutely not cancer-specific. What does that mean? It means a high PSA tells you something is happening with the prostate, but it doesn't tell you exactly what that something is. Think of it as a signal, not a diagnosis.
And this is exactly why a high PSA can be caused by so many different things, right? Any process that disrupts the normal architecture of the prostate, like the stretching from a non-cancerous enlargement or the inflammation you get with prostatitis, can cause more PSA to leak into the bloodstream. Even something like recent ejaculation or pressure from a long bike ride can bump it up. All of these have to be in your differential diagnosis.
Oh, and here is a classic board exam question. Patients who are on 5-alpha reductase inhibitors like Finasteride for their BPH, well, their PSA will be artificially lowered by about half. So if a patient on this medication has a PSA of, say, 3, you have to double it. Their true PSA is actually closer to 6, which might completely change your entire management plan.
Okay, so you have a suspicious finding, maybe an abnormal exam or a PSA that's just persistently high. So where do you go from here? Let's walk through the modern pathway that takes us from that initial suspicion to a definitive diagnosis.
It's really a clear 3-step process these days. It all starts with that initial clinical suspicion from a PSA or DRE. The second step, which is now standard practice, is a multi-parametric MRI. And then that MRI guides the final step, a targeted prostate biopsy.
You know, the multi-parametric MRI has totally changed the game. It basically acts like this high-tech map of the prostate, and it highlights any suspicious-looking areas. Radiologists will then grade these areas on a risk scale, from low to high suspicion. A high-risk score doesn't just tell us cancer is more likely, but more importantly, it lets the urologist perform a targeted biopsy. It's like using a sniper rifle instead of a shotgun. It just vastly improves our accuracy.
But for all the incredible advances in blood tests and imaging, we have to remember one thing. The biopsy is still the gold standard. Seeing is believing, right? And in this case, the only way to confirm cancer is for a pathologist to actually see the cells under a microscope.
And that brings us to our final section. The biopsy is done, the path report is back, now we need to understand what it's telling us. We've got to figure out the cancer's aggressiveness by decoding something called the Gleason Score.
The Gleason Score is actually pretty fascinating because it's not about how ugly an individual cancer cell looks. It's more like urban planning. It's about how the cells are organized into glands. So well-organized, structured glands are like a neat little suburb. They get a low score. Chaotic, disorganized structures are more like a sprawling, unplanned city. They get a high score, which tells us it's a more aggressive cancer.
And the way it's calculated is really beautifully simple. The pathologist finds the most common architectural pattern. That's the primary pattern. And then the second most common pattern. You just add those two numbers together to get the total Gleason score. So for example, a 3 plus a 4 equals a Gleason 7.
Now, to make this system a little more intuitive for everybody, patients and clinicians alike, the raw Gleason scores have been simplified into 5 grade groups. As you can see here, a Gleason 6 is always grade group 1, which is the lowest risk. A Gleason 7 can be either a grade group 2 or 3, and that just depends on which pattern is dominant. And the highest scores, 8 through 10, they fall into the highest risk grade groups 4 and 5.
So, the bottom line is simple. The higher the grade group, the more aggressive the cancer, and the greater its potential is to grow and spread. This number becomes one of the most critical factors when we decide on the next step, treatment.
So we've gone on this journey from a silent disease all the way to a definitive diagnosis and a grade. And this brings us to the ultimate clinical question. Now that we know what we're dealing with, how do we decide who to treat and how? Well, that is the critical topic of prostate cancer management.